Chapter 20 is respiratory inflammation and infection. There's a lot of stuff in this chapter as far as terminology that you will see over and over again. Words like atelectasis, what does that mean? And a lot of you guys with your discussion posts have been tackling some of these words, so that's great. Respiratory infections, very common. They're a leading cause of death. The leading cause of death in young people, children worldwide, are different respiratory infections. Tuberculosis is something that we don't see a lot of here in the United States, which is kind of weird considering that 1 out of every 4 people in this world have tuberculosis. TB affects 2 billion people worldwide. So 1 out of every 4 individuals alive on this earth have tuberculosis. We don't see it a ton here in Nebraska. Last semester we had a TB patient at clinicals, but just every once a year or so, I would say, we see an active TB. Lungs are also at risk for harm by inhalants of different kinds. As far as basic anatomy, you do have 2 lobes on the left side, but 3 on the right side. And the reason for that is because of your heart. Your heart is taking up a decent amount of space on your left side of your chest. The right lobe is a straight shot as far as your airway goes. It's a straight shot into your right lobe. Your upper middle lobes are where you see aspiration pneumonia, which is a very common problem. And the reason it's so common is because strokes, people that have a stroke is so common. It's like the number 2 cause of death in developed nations, a cerebral vascular accident. You have a stroke, and often it affects your swallowing ability. And if you're eating your scrambled eggs for breakfast, and there's a chance it could go right down into your right upper lobe because it's a straight shot. As opposed to the left bronchus, it has to make a right angle turn to get around your heart. Your heart's in the way. So the left bronchus is this right angle turn. Food doesn't get down on the left side very easily, but the right side is just a straight shot. We had that happen in clinicals on Monday, right off the bat. Patient was eating his breakfast and he aspirated. How do you know somebody aspirated? Well, he started coughing right after taking a bite. Pretty good sign. He also had an oxygen sat monitor on. And as soon as he started coughing, his O2 sats plummeted to about 79%, which if you didn't have a sat monitor on, you could probably tell by the fact that his lips were turning blue. Very good sign. Somebody aspirates. Another great sign of aspiration, I learned this from a speech therapist. Speech therapists are the experts on swallowing problems and aspiration pneumonia. She said, look at somebody's eyes. If you don't know if they're aspirating, look at their eyes because they will always tear up. If you get something down in your lung, you always tear up. And sure enough, our patient Monday morning, he had one big crocodile tear running down his cheek. Not because he was sad, it's just a response to inhaling food into your lung. That's very helpful for what we call silent aspirators. Those are your patients at the nursing home often who don't cough. They don't cough when they get their scrambled eggs down into their right upper lobe. They don't cough. But if you're talking to grandma and every time she's eating her breakfast, you notice big tears coming down, she's aspirating. She's aspirating. So then the next thing you could do is take your stethoscope and listen to her right side. If you hear junk, if you hear just the sound of air blowing past food, we call that rhonchi. Sometimes it sounds like rails, but you hear junk, coarse lung sounds in the right side immediately after eating, they're aspirating. Another vital sign, and this happened to our guy on Monday, his O2 sats dropped, but within half an hour, he spiked a little low-grade fever. Low-grade fever, his temp bumped up to 100.6. I mentioned that he had tears coming down, but he wasn't sad. He was actually angry. He was a great guy. I loved him because the nurse tried to take his breakfast away. Oh, you can't have this. You're aspirating. She grabbed his tray and he started throwing stuff and he just got very angry. And rightfully so. I'd be mad if you took my scrambled eggs away too. But it's an ethical dilemma because he's eating and aspirating. What do you do? What do you do? This picture kind of shows that a little bit on the right side, how that right main bronchus is a bit more of a straight shot. The left main sort of takes a right angle turn. You could, in theory, get food in your left side. Some people do, but it's a lot more difficult. Probably the most crazy thing I've seen aspirated into the right main bronchus. We didn't see this until the patient's wife asked, "Have you seen my husband's dentures?" And we're like, "No, I hadn't seen his dentures. Are you sure he brought them?" Chest x-ray in the morning showed what? He had inhaled his top dentures into his right main bronchus. The way he did that was he was having full-blown tonic-clonic seizures when his dentures went missing. Still, nobody could believe it. The pulmonologist couldn't believe it. How did he fit his dentures clear down there? They're sitting right there on the chest x-ray. The mucociliary apparatus, the cilia, I think we had talked about this, or at least there was an exam question way back on exam 1 about cilia. Those are those little hair-like projections that their job is to move mucus up out of the lungs. The nice thing about mucus is it traps germs, it traps inhaled particles. The problem with smoking is it kills off those cilia. The cilia just start dying off, those cells, and so pretty soon you're not able to move that mucus up out of the deep recesses of your lungs. And so smokers have a very distinct smoker's cough, and it's hard to get that mucus up out of there. You do have normal flora in your upper respiratory tract. This is bacteria that lives there, and it's actually very important. It does an important job. We're not sure what that job is, but we know that it's important. If we start disrupting your normal flora, you could start having weird problems. Deep down in your lungs, though, in the lower respiratory tract, in the alveoli, you don't have normal flora. You don't have bacteria living down there. It's a pretty sterile environment. Most important feature of the lungs are the alveoli. And these are these tiny little air sacs, just microscopic air sacs that allow oxygen in. When we inhale, we oxygenate. Inhalation equals oxygenation. We breathe in, oxygen floods our alveoli and diffuses out into the capillary, which is the blood vessel running outside of each alveoli. When we exhale, when we breathe out, that's called ventilation, and we're getting rid of carbon dioxide. Remember, carbon dioxide is an acid. Throwback to our chapter 8 acid-base balance. So we're breathing out that acid, we're breathing in oxygen. The oxygen binds to the hemoglobin on those red blood cells. The fancy word for that is oxyhemoglobin. It's the hemoglobin that has oxygen attached. SaO2 is the vital sign that we can measure with a little finger probe. We just put it right on the finger, and it's the percentage of saturation of hemoglobin with oxygen. If every single little tiny hemoglobin is saturated, meaning every single binding spot on every single red blood cell has an oxygen molecule attached, your O2 sats, don't say stats, S-T-A-T, it's sats, S-A-T, saturation. Your O2 sats are 100%. That was invented, actually, the O2 sat monitor and also the end-tidal CO2 monitor. Both of those fascinating, those were both really groundbreaking technological advances for the care of the ICU patient. They were invented for fighter pilots in the US Navy. The problem with flying like an F-15 fighter jet is those guys pull so many G's and they go so high up in the atmosphere that they black out from time to time. And so the US Navy's trying to figure out how to prevent their fighter pilots from blacking out. So they invented the O2 sat monitor initially, and then later on they invented the end-tidal CO2 monitor. The O2 sat monitor is measuring oxygenation, how well you're breathing in. The oxyhemoglobin dissociation curve, again, not something a bedside nurse would ever need to know. It's kind of cute, though, the idea being that if you have a fever, if your pH drops, a couple different things like that, oxygen will release from the hemoglobin more easily. Other things will cause the oxygen to bind more tightly to the hemoglobin. I will say that the knowledge of the oxyhemoglobin dissociation curve has never changed the outcome of a single patient ever in the history of the world. But if you go work in an ICU somewhere, your very first day, the clinical nurse specialist will teach you again about the oxyhemoglobin dissociation curve. Every ICU job I've ever had, during the orientation, they teach you this curve. Oxygen levels and erythropoietin, kind of interesting. Your erythropoietin, secreted by the kidneys, stimulates your bone marrow to produce red blood cells. If you think to yourself, self, I'm a competitive athlete. How could I improve the number of red blood cells in my body? Maybe the next time I go race at the Tour de France, maybe I would improve my times if I had more red blood cells. And you would be correct. Erythropoietin is on the list of banned performance-enhancing drugs that they test for in all professional athletics, the Olympics, Tour de France, all those things. Because if you have more red blood cells, you have more oxygen binding sites, which means your VO2 max goes up, which means you can run faster, you can bike harder, you can swim faster for longer distances. EPO is a performance-enhancing drug. And I believe that's what Lance Armstrong did. Yeah, I'm pretty sure. The patient that I was mentioning that we took care of on Monday, she came in on Sunday, and we put her on her non-invasive ventilator to blow down her CO2. She had a separate problem, a totally separate problem, which is that she was on hemodialysis because her kidneys had stopped working probably 5 years before. She'd been on hemodialysis for a long time. And on Monday, in the room, she got hemodialysis. So the nurse brought this big old machine in, hook her up to dialysis, and a drug that they give in dialysis popped up on her MAR, EPO. And it's to treat the low red blood cells that patients whose kidneys have shut down have. They have anemia because their kidneys aren't making EPO because their kidneys are pretty much dead. Back to our Lance Armstrong thing, a natural way that people are trying to increase their erythropoietin is by training at really high elevations. So if you go out to Denver and train at Mile High Stadium, for example, your body will naturally start producing higher amounts of red blood cells because the oxygen content is much lower. I have at home, I've tried it a couple times and it's kind of dumb, but it's called a hypoxia training mask. It's pretty popular right now. You'll see people running with this crazy looking mask that's supposed to decrease the amount of oxygen you're breathing in so that your kidneys send erythropoietin to your bone marrow to produce more red blood cells. More red blood cells. Anyway, kind of interesting. We'll keep trucking. Your diaphragm is a very important muscle in your body. Your diaphragm separates your chest from your abdomen. When we breathe in, the diaphragm moves down. When we breathe out, the diaphragm actually moves up. And the very important nerve that innervates the diaphragm is called the phrenic nerve, and it originates at C4, so cervical vertebrae number 4, which is right in the middle of your neck. If you break your neck and sever your spinal cord, above C4, you will stop breathing, which is a problem. And not many people survive that injury. Not many people survive. The first person who survived a C1, cervical vertebrae number 1 fracture, he severed his spinal cord at C1, was Superman. Superman, the actor, what's his name now? He died here recently. Does anybody know the actor who played Superman? I want to say Keanu Reeves, but that's totally not right at all.
It was
Anyway,
Christopher Reeves.
he survived his C1 fracture because the way the accident went down is he was at a horse show and was riding his horse, jumping. I don't remember what that's called, where you ride around and you jump your horse as a competition. And he fell off of his horse, broke his neck, immediately stopped breathing. But there just happened to be a doctor in the stands, an anesthesiologist, who had in his pocket an ET tube, an endotracheal tube. So he was able to intubate Superman immediately and breathe for him. And he ended up living for years and years after that. Actor that played Superman. I'm gonna Google it, sorry. I'm on my. Christopher Reeves, yes, that guy. Oh, so he died way back in 2004. So he's a cool dude though, because he didn't let his spinal cord injury take him down, and he just spent the rest of his life spending a ton of money on spinal cord research. And near the end of his life, I remember watching videos of him walking. They had built an exoskeleton robot kind of thing that he could sort of control with his mind, and was getting it. It's called the Christopher and Dana Reeve Foundation for spinal cord injury. But the phrenic nerve originates at C4, innervates the diaphragm. For trauma nursing, just a weird little factoid that is always on the trauma nursing exams. Sometimes if you have blood in your belly, let's say you have an internal bleed that nobody can see because it's inside your belly, but you have blood that's irritating your diaphragm, that phrenic nerve can sense that, but your pain is not down in your diaphragm, it's up here, often in your neck or even in your left shoulder. It's that same nerve, the phrenic nerve, that's irritated from the blood in your belly. So for trauma nursing exam questions, anytime you have a patient with left shoulder pain, you have to be worrying about them bleeding into their belly through that phrenic nerve. Kind of a weird symptom. That's called referred pain. Other muscles that you have are the external intercostals, the internal intercostals, sternocleidomastoid. That's a real fancy word. I like saying that. It just kind of rolls off your tongue, but that's just that muscle in your neck there. It's a part of your respiratory system. And so our patient on Monday, different patient than the first one I was telling you about, the patient who aspirated, he had retractions. After he aspirated, he had retractions. And what that means is we could see his accessory muscles working extra hard. And one that was working was his sternocleidomastoid. So his neck muscle, what it looked like, would kind of bulge out. You could tell that his neck muscle was working to help him breathe. And that's called a retraction. Often we see the retractions between the ribs in the intercostal muscles. If you see retractions between the ribs, that person is working hard to breathe and something needs to be done. Especially in kids, we can see kids retract all the way up. So they'll often start just in their lower ribs, right between the few lower ribs. You'll see the muscles suck in between the ribs. And then as the breathing gets more labored, those retractions go up higher and higher and higher until you'll even see retractions right under their collarbone here. And we call those supraclavicular retractions right around the collarbone, which is called the clavicle. That's a pretty sick kid who is working really hard to breathe. And we have to fix it right away, figure out how to fix it. Ventilation and perfusion. The idea of the VQ, the Q stands for perfusion. Somewhat confusing, but if we go back to that picture of the alveoli, the V for ventilation is talking about the airway, the air inside the alveoli. The Q, which stands for perfusion, don't ask me why, they're just trying to confuse you. The Q is talking about the blood flow around that alveoli. So we have ventilation and we have perfusion. And you can have a problem with either of those things. With this air sac, imagine if this air sac, the alveoli, was full of snot, mucus. Well, suddenly we have a ventilation problem. Or what about if this blood vessel had a blood clot plugging it up? Now we have a perfusion problem, a Q problem. Most common reason we would do what's called a VQ scan, I'm going to skip back to that slide. A VQ scan would be to look for a blood clot in the lungs, which is called a pulmonary embolus. Blood clot in the lung, we do a VQ scan. I haven't seen a VQ scan done for about 20 years. It's been a long time. No reason to do it because our CAT scan machines are much faster now and much more accurate. If you ever see VQ scan, it's only because the patient maybe is too big to fit in the CAT scanner. The CAT scanners I think that we have can only handle a patient of up to 750 pounds. So you get somebody that's heavier than that, and the doctor might order a VQ scan. Hypoxia, which is low oxygen levels, stimulates the pulmonary artery to vasoconstrict. Low oxygen, and the pulmonary artery starts clamping down. This can cause a problem if we have chronic pulmonary vasoconstriction. That's the same as saying pulmonary high blood pressure, what's called pulmonary hypertension. And what that does is causes that right ventricle to work extra hard. Remember that right ventricle is pumping blood out through the pulmonary artery, which branches to go to both lungs, that right ventricle. So if your lungs are bad, you can have really high blood pressure, but just in that pulmonary artery. And that's what causes right-sided heart failure. Right-sided heart failure. It has its own special word called cor pulmonale. Cor pulmonale is that right ventricle is failing because the lungs are crap. The lungs are bad. Now we've got right-sided heart failure on top of the lung problem. So a ventilation perfusion mismatch is when the air cannot flow into the alveolus or the blood flow around the alveolus is altered. A PE is a very common cause of VQ mismatching. The clot prevents blood flow to the alveolus. I can't think of any other real times you will hear the word VQ mismatch. It's almost always just talking about a PE, pulmonary embolus. So what controls our breathing? We don't consciously think about each breath that we take. We just naturally do it. Yeah, and it's part of your brain called the medulla. And it has what are called chemoreceptors, which is a fancy word for chemical receptors, or little devices that sense how much CO2, how much carbon dioxide you've got floating around in your bloodstream. Also senses your pH, so how acidotic are you? So as your carbon dioxide rises in your blood, you become more acidotic. And that stimulates your brain to tell your body to start breathing faster, start breathing deeper. You can experiment with this at home if you'd like. Try holding your breath for as long as you can. The longer you hold your breath, the higher your CO2 will climb, and the more acidotic you'll get. The nice thing about trying to do that is you can't hold your breath for too long. I had a cousin when I was a kid, I remember. He was a naughty dude. I wonder what he's up to these days. He grew up into a fine young man, but when he was a child, he would get so mad at his mom that he would hold his breath until he passed out, which just freaked his mom out, my aunt. But guess what? As soon as he passed out, he started breathing fine. He built up that hypercapnia. He got a little bit acidotic, so much so that he would pass out and then his breathing would return to normal. Acidosis, retaining carbon dioxide. The opposite problem, if you drop your CO2 too low, you become alkalotic. And you can definitely try this at home as well. Hyperventilate. Breathe as deep and as fast as you can for as long as you can, and see what happens. You'll start feeling pretty crappy is what will happen, and your fingers will start tingling. When you're hyperventilating, your fingers and toes start tingling, and if you keep it up, pretty soon they're going to clamp down, what's called a carpal pedal spasm. Your hands and your feet will actually spasm. It's called a form of tetany. Your muscles just cramp up, and that's what it looks like. Your hand is all cramped up, and you'll be freaking out thinking that you just killed yourself. We did this in the ER late one night because I remember when end-tidal CO2 monitors were a brand new thing. And one of my jobs at that time was to roll out end-tidal CO2 to the hospital and to teach all the nurses what it did. So the way we did that is middle of the night, 2 a.m., there were no patients in the ER, and we had a competition. All of us nurses put on an end-tidal CO2 monitor, which is just a nasal cannula hooked up to our little bedside cardiac monitor. And then we would hyperventilate. and we had a competition to see who could drop their CO2 the farthest. And remember, a normal CO2, 35 to 45. And my friend Mindy, who is now the trauma nurse coordinator, I think in Grand Island, she won. She dropped her CO2 clear down to 8. And then she didn't quite pass out, but she fell. She fell onto the bed. We thought we had killed her. She dropped her CO2 down to 8, and she started having carpal pedal spasms. That's called respiratory alkalosis. CO2 is an acid. She hyperventilated, blew all the acid off, dropped her CO2 really low. The whole point of this slide here, what it's kind of trying to tell you is that there are certain patients who always have a high CO2. These guys always have COPD, they have bad lungs, and we call them the 50-50 club because their ABGs, if we were to draw arterial blood gases, their CO2 is always high at about 50, but their O2 is always low at about 50. So they are what we call the 50-50 club. End-stage COPD, they could have been this way for years and years. The one difference is that for most of us with healthy lungs, carbon dioxide is what tells our body to breathe. When our carbon dioxide starts getting higher, it signals to our brain that we need to breathe. Take a deep breath, blow off some CO2. For those end-stage lung patients who live in the 50-50 club, their drive to breathe is their low oxygen levels, what we call the hypoxic drive. The CO2 is always high, so their brain learns to tune it out. That's the one patient, it's a very rare patient, contrary to popular belief, very rare patient. If you put oxygen on them, because you're worried about their SATs, put oxygen on them, they could stop breathing because you fixed their oxygen that's really low, but they're used to it being low. And their hypoxic drive, if suddenly they've got high flow oxygen in nasal cannula, you just erase that hypoxic drive to breathe, they could stop breathing. That's why oxygen technically is a medication that requires a doctor's order. Oxygen is a med, requires a doctor's order. Don't just be putting oxygen on people all willy-nilly without thinking about whether you have a doctor's order for it. I knew a nurse that lost her license for this very thing. She put oxygen on a patient in the middle of the night, just a couple liters, because her oxygen sats were low. The physician, when he came in the morning, was very angry that she had not called him for a doctor's order. And he reported her to the State Board of Nursing. She lost her license for practicing medicine without a license. That's what they call it. Practicing medicine, because we're not doctors, we can't prescribe stuff. And so don't just be putting oxygen on people unless you have a doctor's order for it. Moral of that story. It is scary, and I just told you that, and now you'll be scared, but I put oxygen on people all the time without an order. But
Our doctors will say, like, they were saying to us that if they're deciding below 90 and they can't get out of the 80s, go ahead and put one.
And
never thought about it.
s- so yeah, the here in Lincoln, she said that where she works, her doctors expect them to put oxygen on and then call if the oxygen doesn't help. And that's how most hospitals work. Um, so my only kind of the take home point of this is check your standing orders to see, man, my battery's about to go. My thing. Check your standing orders to see, because most hospitals do have a standing order, which is technically a physician's order that covers your butt. And if so, do look into that. If your nursing home or your hospital does not have that standing order, see if you can get that in place just to cover yourself, because technically you're practicing medicine without a license.